For the agent that must be in the know, Medicare Industry Insider discusses critical insight, noteworthy trends, and upcoming issues in the Medicare market.
Deciphering and debating the legislation, regulation, and what's happening in the market. I'm Chalon Jackson.
And I'm Rachel Bremeyer, and we're going to talk shop, dive deep into these complex topics, and make them understandable and actionable.
If you've ever wondered where the world of Medicare is going and how to prepare for the future, Medicare Industry Insider is the resource you've been looking for. Welcome to Medicare Industry Insider. I'm Chalon Jackson.
I'm Rachel Bremeyer.
And holy cow, what an AEP. If you haven't figured it out yet, this is our holiday episode, much to Rachel's disapproval. This is going to be corny as all get out. In fact, the title for this episode is A Christmas Medicarol, and we're going to talk about AEPs past, present, and AEPs yet to come. So this is our conspiracy / speculation / let's just talk shop for a little while episode.
Yep.
And I think we've got some really fun things to go over.
So, Merry Christmas to everyone. We'll jump into past. We'll start with the Christmas past, or Medicarol past.
AEPs past.
AEPs past. Mm-hmm. We'll start with where Medicare came from. So Medicare obviously started in 1965. Johnson signed, and the first ever, which I think is pretty cool, the first ever recipient of Medicare was Truman. And then the other fun fact that I thought was interesting was Part B premium was $3, and the deductible was $40. It's
Absolutely.
so interesting.
I mean, quite a bit of inflation. So so we looked at a bunch of statistics and things when we were preparing for this episode, and it's amazing what premiums have done in the past, just 20 years. So you look at Part B premiums, 1966, $3, 2000 Medicare Part B premium, $45.45. And here we are today.
Yeah.
Just, we kept it pretty consistent until about the year 2000. And then things have been skyrocketing since then. But, we're going to go through again some of this history pretty quickly just because there's some cool things to note that, when Medicare first started in 66, signed into law in 65, that, it didn't originally cover folks with disabilities or with end-stage renal disease. That wasn't actually added until 1972. And it was linked to eligibility with the SSI program through Social Security.
Yeah, and then if we keep going in time, 1973 was when the HMO Act started up grants and loans to develop this particular product of an HMO. So it's kind of interesting to think about that particular product line didn't exist until 1973.
Yeah, and what I think is interesting, a lot of agents would probably not assume that kind of the first inklings of what is now Medicare Advantage started that long ago, full 50 years ago.
Yeah, because a lot of people historically think of it only picking it up a little over 15 years ago. So it is interesting that that act to create grants and loans and develop the product of an HMO happened that long ago.
Absolutely. And so many interesting things that happened over time. In 88, we had the Catastrophic Coverage Act that created a lot of new things, including hospital and skilled nursing benefits, changed the way those worked, covered mammography, covered outpatient, it included an outpatient prescription drug benefit and a cap on patient liability. But I think one of the biggest changes that a lot of people, if you've been in the business for a long time, this is, not news, but CMS, the Centers for Medicare and Medicaid Services, that we all know and love, didn't exist until 2001.
Yeah, and it was actually called the Healthcare Financing Administration. They changed the name in 2001 and renamed it to CMS. So I think that's really interesting because, I don't know, I just never thought it would have ever been monitored by anything besides CMS until we started digging into the history in the past.
Absolutely. And, going from there, obviously, kind of stepping into the modern era, 21st century, we had some big changes coming up. 2003, we saw the Medicare Prescription Drug Improvement and Modernization Act, and obviously that made some huge changes to Medicare, created this new outpatient drug benefit that became Part D. And if you're ever looking for an interesting listen, there is a NPR Planet Money episode about the Congressional Budget Office and kind of what their role is.
I think you told me about that.
And the case study they use in talking about it is actually back in 2004 when the Congressional Budget Office had to write up the Part D program and what they expected it to cost the federal government. Let's just say the numbers are pretty comical. But it's a really interesting listen if you ever have a chance.
Yeah, I will have to check that out after this because I'm very nerdy also and enjoy that kind of stuff. In 2006, provided through private health plans, allowing for competition and among health plans to foster innovation and flexibility and coverage, they basically allowed new preventative benefits and made numerous other changes. So prior to 2006, MMA created a temporary prescription discount program. So we're going to see throughout 2006 through 2015 a lot of changes in prescription drug, like looking at what is this prescription drug and should we make something separate, because it used to be provided through Medicare supplement plans.
Absolutely, a certain number of them. And that's something that has also been interesting. Of course, prior to 1992, Medicare supplements were broadly different, wildly speculative. They covered totally random and different things.
Like nursing home coverage.
Yeah, there was no consistency and really no shopability. And if you just watched our Value of an Agent and FMO episode that came out a couple weeks ago, we talk a little bit about back in the day, the agent was really the only source of information, and they usually worked for a carrier. It was very difficult for people to compare insurance products. So 1992, when they created the standardization of Medicare supplement plans, and then going forward through 05, 06, when drug plans came on the market and the Medicare Advantage started becoming a thing, we also saw in that mix 2010 when they modernized the Medicare supplement plans, got rid of plans E and J, modernized some of the benefits, and continued to try to improve on those plan designs.
Yeah, now it's a lot easier. There's a nice little graph you can look at. You can see which plan covers what and make a more informed decision and know that they're all standard and stable and they all do what they're supposed to do. So.
Yep.
And then 2015, that was another really big year that I in particular remember was MACRA. So the Medicare Access and Chip Reauthorization Act started in 2015. And the main thing was to figure out how to shift money. There was tons of different things that it covered, obviously. But some of the main topics it did was basically take away first dollar coverage, where now a client was responsible for first dollar coverage. So that plan F and J that people were using prior no longer are things that people are eligible for after 2020. And then the other big one was it kind of initially was looking at payment to physicians.
Sure.
And changing how physicians paid. That got put on the table and taken off a ton of times. I don't want to misquote.
Pretty much every year.
Yeah.
Every year there proposes to cut physician pay.
Still
Back, walk forward. Every single year this is an issue. But 15 was definitely kind of a bellwether moment for making sure physicians could still afford to treat Medicare patients. And some of that came from saving Medicare program money by eliminating those other supplements. But lots of changes to increase efficiency and quality of coverage. And then, going on through that, and listen, we'll talk about that in the future section. But, man, it's been 2010. It's been 13 years since we had any major shakeup with the med sub market. Maybe it's time.
The future. I don't know. And another big thing historically, before we get moved to the present, is just the role of an agent and FMO. We did talk about that a couple weeks ago in a different podcast, but essentially the main takeaway is that an agent usually worked for a captive organization or a carrier in particular. Information was gathered and basically when you met with that agent. So there wasn't any other way for a client to figure out what to enroll in. They were looking at that agent to give them information to help them make a decision.
Absolutely. And I think, something to be said for kind of the history of Medicare compliance as well, where we've seen, absolute Wild West, total lack of oversight, people, doing a lot of different things. Some agents working obviously totally responsibly, some agents pushing the limits and testing the boundaries. And then, of course, we saw the scope of appointment come on the scene for the first time. We saw that 48-hour rule come on the scene for the first time. We've since seen that walked back and, got rid of the 48-hour rule. Unfortunately, that was a short-lived experience just a few short years later. Now here we are present day.
Yeah.
48-hour rule is back. And a lot of other things have been going on as well.
Yeah, so I think we're comfortably in more of like the present era now. So we kind of talk about what we're currently seeing. It's been interesting to see kind of the shift in supplements and Advantage. We saw Medicare spending grow 8.4% to almost $1 trillion, because it was 900.8 billion, which is crazy, and that was in 2021.
Yeah, so they actually are anticipating when this data, and the data won't come out for a while, but they some initial reports anticipated that 2023 will be the year that Medicare spending exceeds $1 trillion for the first time, which is a big number.
Yeah. So I think looking at that and how does that affect everything, we saw the Inflation Reduction Act in 2022, which is not too long ago. Definitely one of the major changes was prescription drug plans. We're going to see in I guess next year, so it's kind of future, but we're going to see a drug cap of $2,000. And that definitely changed a lot of other things like vaccine coverage. So we're looking at little ways to help mitigate some of the cost for seniors with the Inflation Reduction Act.
Yeah, and I think that's, if you look at the present day, that's definitely one of the trends within, whether you're talking about Congress, CMS, the White House, any other regulatory body, like the overwhelming narrative is prescription drugs are one of the biggest threats to financial security and health security for senior citizens or people on Medicare, and that's one of the biggest problems that they plan to address in the near to mid future is how do we make prescription drugs more affordable, especially things like maintenance meds for chronic conditions, but also those extremely high-cost meds that not only threaten the lives and well-being of certain people, but the financial stability of the Medicare program.
Right. The other big thing that we're seeing is the shift in the type of coverage people are selecting. And historically, you would see original Medicare and the Medicare Advantage, and I think we see for the first time we're predicting, I think it happened this year, correct? In 2023, where Medicare Advantage surpassed original Medicare.
Absolutely. It's just, something that it's one of those things, kind of like they say the Medicare trust fund's running out of money, and they say that every couple of years, and every couple of years they push that date forward. Medicare Advantage saw the opposite. They kept saying, well, by 2050, half of people will get their coverage through Medicare Advantage, and then it was 2040, and then it was 2035, and then now it's today.
It's today.
50% of people, more than 50% of people that have both Part A and B get their coverage through a Medicare Advantage plan. And I think the big takeaway that we talk about this all the time, but the big takeaway I want agents to have is the other 48% of people don't all have a Medicare supplement. Very small chunk of people that have a Medicare supplement. There's a lot of folks that have maybe retiree or union coverage, folks that have VA benefits or TRICARE, folks that have Medicaid,
still in their group,
Medicare, still on group benefits. It's, and then there's always that tiny little sliver of folks that truly just have original Medicare and nothing else. But the Medicare Advantage has actually eclipsed the number of people enrolled in Medicare supplements a long time ago. It's just been a discussion of original Medicare versus Medicare Advantage because CMS doesn't track med subs the same way that they track Med Advantage.
Yeah, so I mean that's definitely a big shift because I remember even when Medicare Advantage first came out, and this is me dating myself a little bit, but every time I would talk about a Medicare Advantage plan and try to get an agent to pick it up and have it part of their portfolio, the first pushback would be like, well, I want to wait it out a little bit. I don't know how long they're actually going to be around. So it was over and over and over, and it was me saying like, don't bash it, like what, please don't bash it. Like even if you pick it up down the road when you're talking to a client, don't bash it because you never know when you might change your mind, you might shift, and I think we're past that now. I haven't heard that objection in a very long time. If anything, it's making sure they're balanced portfolios.
When I started in this industry, you never could have convinced me that there would be a time in my career where I knew agents who had never sold a med sup. And I know several. But I'm not saying that's the right way to do business by any means. I think you should be equipped and able to offer both products to your clients unequivocally. I believe that's true. But we knew tons of people who only sold med sup.
Oh, yeah.
Tons. I never would have thought we'd be in an industry where I knew a lot of agents that only sold Medicare Advantage, but here we are.
Yeah, I even had one agent talk to me a few weeks ago and said, I should have listened to you sooner and started talking about it sooner. I'm worried my clients are going someplace else because I was bashing it. So
Yeah.
it is kind of interesting, just the change in tone and the change in the and what type of products are developed, what is offered, and how appealing each one is based on where those people live too.
Yep.
The other thing that we're looking at is a lot of changes to compliance. In 2024 final rule, 2023 final rule. We haven't had the 2024. That's future. We're going to speculate in just a second. 2023 final rule. We saw a lot of compliance changes. You already brought up that 48-hour rule coming back. Part of it was due to basically making sure that, 2020 happened, so COVID. I feel like everyone now has in their mind pre-COVID and post-COVID. And all the post-COVID years all kind of blend together for me. But anything during COVID, 2020 to 2022-ish almost, people got bombarded with virtual appointments, phone appointments, advertisements on their TV because they were at home and they were just sitting there watching it. Lots of phone calls because people were actually at home to their landlines. And we saw a lot of complaints to Medicare from call centers, from people not realizing what plans they were rolling in. And so some of the compliance changes were an attempt to help cut down on some of those CTMs.
Mm-hmm. Absolutely. And, I think the big takeaway from that is, and I always say this kind of tongue in cheek, but, at the end of the day, Medicare doesn't care so much what the outcome of a complaint investigation is. They just don't want the phone to ring. Mm-hmm. And, I say that jokingly, but at the end of the day, that's kind of the way it goes. CMS doesn't want the phone ringing with complaints. They want the phone ringing with questions, maybe, sometimes, but definitely not complaints. Mm-hmm. So a lot of this was a heavy-handed approach to reduce those complaint numbers, and whether we like it or not, it has actually worked. If you look, complaint numbers are down on that downtrend from 2021. Now, how much was that the effectiveness of the new regulations, and how much of that was bad actors going, okay, we get the picture, we'll ease up a little bit. Either way, it is having an impact. And of course, as we go forward, there will continue to be changes every single year. But I think one of the biggest things when we start talking about drug coverage, like we mentioned in the past, there's always been turmoil over how to get prescription drugs. Way back in the 2000 election, Bush versus Gore, that was one of the key talking points, was seniors can't afford their medications. And we created Part D. It's been working great, but there's the donut hole. And the donut hole has always been a big issue, especially now, maybe more than ever, because back in 2020, you all may remember, we closed the donut hole. But of course, we didn't really close the donut hole. We just reduced patient liability. Mm-hmm. We shrank it down to where they were only paying 25% for brand name and generic drugs. But the unfortunate part was there's some glitches, and those glitches continue to this day. So talking about present day, you run a Part D plan right now, 2023, 2024 plan. For a 2024 plan, your clients will actually, if they have a high-cost, high-utilization drug, they will spend less money on a brand name drug than they will on a generic because of the way that coverage gap discounting works. If they're on a brand name drug in the coverage gap, the donut hole, the manufacturer is paying a 70% rebate that is counting towards that maximum out-of-pocket cost, resulting in an actual client out-of-pocket of around $3,300. If they're on a generic drug, Medicare is paying that 70%, but it's not counting towards that client's costs. So they're going to end up paying close to $8,000 out of pocket. Now, come 2025, we'll have that $2,000 cap. It'll be a much different story, but 2024 is going to be a very messy year for certain beneficiaries on high utilization drugs. And for the past almost decade, get a generic, go on generics, they're cheaper, has always been the way that we have run drug plans. But in this particular year, it's going to be a weird, glitchy situation.
Well, that might be a perfect way to go into Christmas Future. Mm-hmm. We'll go with the ghost of Christmas Future and transition our Medicarol into speculation. So anything we say or do after this is just our chit-chat and speculation of what we think the future will look like.
Only hold it against us if we're right, is what we're trying to say.
So that goes nice hand in hand into prescriptions. You were talking about the $2,000 cap, and how that could definitely help a lot of people saving costs and cutting back where that cost is going to be. But what is the effect of that? And something that we both have talked about quite a bit is who's paying for the extra. And right now it's the prescription drug company, the manufacturer, and then the client paying the majority of that drug cost. It's going to shift after that $2,000 cap is hit to the actual insurance carrier. So what are they doing to mitigate that cost? Is it cutting benefits? Is it maybe adding premiums? Is it copays? So I definitely we'll see a lot of shift in where's that money coming from going forward.
Yeah, and I think there's a lot of ways for carriers to get creative in how they write their contracts with PBMs, with providers, with manufacturers, but that is like we said, that's the biggest, most heavily scrutinized chunk of this industry right now is drugs. There's continuously legislation rolling through Congress, things going through committees, things going through regulatory processes to look at how can we shrink the impact that PBMs especially have on the cost of a drug. Some of those proposals are as simple as prohibiting clawbacks, not allowed to claw back costs from a pharmacy, meaning that it's more cost effective for a pharmacy to actually dispense those drugs, prohibiting PBM payments from being based on the actual cost of any individual drug. It has to be based on the cost of that negotiation service, not the cost of the drug itself. So kind of removing it from right now they're kind of getting paid a percentage of what they save the plan on a given drug. So decoupling that process is one of the proposals. And just looking at, how can we make this a little more of a fair playing field for some of the smaller PBMs out there, as well as just, not creating incentives that are at odds with the Medicare program goal of providing low-cost, high-quality care to beneficiaries.
And we even have a podcast on PBMs. If you're interested in hearing a lot more about PBMs, there's a lot of news articles right now on PBMs and the value and the purpose of a PBM. Yep. So we probably are going to still see a lot of that coming up in the news, just because drugs are continuing to be a huge topic, especially with the Inflation Reduction Act is also going to be capping prescription drugs in the next couple of years, every couple of years that we've seen. And that's also been back in the news of can we actually do this? Like we said it was going to do it, and then initial Inflation Reduction Act. But as the years progress, that will still continue to be something that is going to be looked at. So it'll be interesting to see.
Well, and I think, looking at all of these things, we're talking about drugs, we're going to talk about quality measures and some of the issues with that, some other things, but I think the big point that I would have you take away as an agent or an agency owner is realize that next year, 2024, is likely to be a little chaotic because, we've all seen how this AEP turned out, and it was a great AEP with a lot of moving parts. Those same parts are going to be moving next year, but it's also going to be an election year.
Yeah.
Which is going to make it a lot more difficult to break through the chatter. There's going to be, there's no doubt in my mind that all of these things will be political talking points during the election cycle next year.
We even looked, it's not just presidential election. There are, I think, over 30 state elections.
You've got senators, you've got House of Representatives, you've got your state and local elections. And don't think for a minute that your state elections don't matter, because that's what's going to impact things like your ancillary products. It's going to impact your Medicare supplements. I don't know if you all noticed, but a lot of states, you know what? This isn't even on the list. We're going to speculate for a minute.
Are you talking about
birthday and anniversary.
We didn't even talk about
Okay,
it on our news.
this isn't on the list, but we're going to talk about it because I've got thoughts. Birthday and anniversary rules. Obviously, for the past decade, we've had 4 states that have birthday and anniversary rules, Missouri being one of them. In the past 3 years,
4 states,
in the past 3 years, we've had 10 states add birthday and or anniversary rules where someone can change bed subs without underwriting. And on the surface, these seem like such a good deal for beneficiaries because they can go to a lower rated plan without underwriting. But what I can tell you, what we see in every state where they do this, reduces plan choice. It reduces the number of carriers offering plans in that state, and it raises premiums across the board.
Lowers commissions for agents
Lowers commissions. So it's not all good news, by any means. It's not all bad news. It's great for the first like 2 or 3 years. No problems here. My point is there's a group of people called the National Association of Insurance Commissioners, and they do great work coordinating between the states what different insurance commissions around the country do to regulate the insurance industry. And at times they provide a lot of high-level guidance to help create model language for regulation that needs to occur at the state level, but really needs to be a little more unified across the board. But man, I tell you, like there's so many of these states that have popped up with this just in the past few years.
And they're all slightly different too.
Yeah, but there's so many similarities. There's no way. You can't tell me there's not conversations happening at the Association of Insurance Commissioners that are talking about implementing this in more states. And I want to be very clear. I'm not saying that's good, bad, or indifferent. I'm saying you should be aware and you should know how it impacts your industry. And if it's something that concerns you that it might occur in your state, talk to your local reps. Talk to if you've got an insurance commission or advisory board or anything like that. Start finding out how to get in contact with them. These things impact you at a state level too. It's not just CMS.
And I would say if you are confused or not sure which state has some sort of rule, we have a running list with the specific regulations and changes and like what that actually means for that state. So another resource for an FMO if you are looking for some of that as well. But yeah, we didn't even have it on our list. And yes, definitely a big thing that I think will shake out. And it may end up being something like, who knows, maybe every state starts implementing it and then the government steps in and sort of, this is just me speculating, and makes it across the board, because the purpose was giving people options. Once they enrolled, the only way you can switch is through underwriting, and if they don't have that option. So
Well, so we've skipped ahead a little bit.
We have.
No particular order for this, but since we're on the subject of Medicare supplements, let's talk about that, because there has been a lot of shift with more and more people going to Medicare Advantage, with changing dynamics in both the MedSup marketplace and who is enrolling in MedSups. There are a lot of changes and concerns about the future of the MedSup market.
Yeah, that is a good point. We even talked about how Medicare Advantage is shifting, and now we've got, half the people enrolled in Medicare Advantage for the first time ever. Part of that could be the reason or why people are enrolling people in what plans they're picking. So if you look historically at Medicare supplements, that is a plan where agents tend to put your sick people or your wealthy people who are willing to pay for the convenience of not having to never see a bill. What happens with that is basically the MedSup claims per capita spending on original Medicare then goes up, which in turn raises the baseline payments, which we give to Medicare Advantage.
Just self-fulfilling prophecy here, folks. So if you're an agent out there, and listen, I understand you, like, everyone wants to do right by their clients. If you have folks that are really sick and you're putting them on a Medicare supplement, I understand. But doing only that, putting your sickest people and your rich folks on MedSups and putting the folks that can take a little financial risk or that are kind of healthy, putting them on Medicare Advantage plans, if anything other than government is going to be the death of MedSups, it's that. Because, check out any carrier, look at the rate increases we're getting, look at the loss ratios, and it doesn't mean this is universal across all carriers and all markets, but if you look at it, this is what's happening. Carriers are experiencing crazy loss ratios right now. Now, part of that can potentially be blamed on the pandemic. People delayed care, chronic conditions turned into acute needs. We saw a lot of elective surgeries that maybe are now not elective because they waited too long. Like, there's all those factors too. But, like Rachel mentioned, the higher the claims go up on those MedSups, obviously that means they're going up on the original Medicare side as well. It increases how we calculate that base rate that Medicare Advantage plans are bidding against. So every time you see a MedSup carrier with a bad loss ratio, just understand that means more money for MA, better benefits, harder to sell against, harder to get folks interested in a MedSup, because it's going to raise the prices on those MedSups as well. And again, it doesn't necessarily mean that you should put folks in a MedSup just to help even the market out. Like, do what's right by your clients, but just understand kind of how that is impacting.
It's a trickle effect.
Yeah, exactly.
So since we're talking MedSup speculation, we might as well go to Medicaid or Medicare speculation. Go to Medicaid speculation, because one of the big things in 2023 was the Medicaid redetermination. And obviously that was something that during the pandemic where anyone who got onto Medicaid didn't lose it. And that was partly to make sure that people were taken care of when finances were tight, when inflation was going up, people were sick, they couldn't go to the doctors, basically to help people when they were in a crunch. Well, now they're looking at everything going, okay, we have to lessen the load on Medicaid. Let's redetermine who is actually eligible and who's not.
And if you've been watching the news, it's been going really poorly. It really has. So here's the deal. The estimates have been just like all over the place. We're supposed to be totally done with this process by May 2024. You're supposed to be able to redetermine everyone. It hasn't been working very well. Estimates placed anywhere between like 7.5 million and 24 million that would lose coverage. Well, we've already disenrolled over 10 million, so the low end estimates are not accurate. But here is the catch. States have been handling it really poorly. CMS has had to step in and say, you need to stop processing disenrollments. And they've done that with over 12 states.
Yeah, it's crazy.
So because, and a lot of it is paperwork issues. If you look at some of the states, they'll tell you that over half of the disenrollments are due to bad paperwork or missing paperwork. People just aren't getting their paperwork turned in, or the state Department of Health has a bad address for them, or things like that. And of those 10 million, several million of those, almost half, are kids literally losing CHIP. So I think that's another thing to be aware of. This is not affecting your dual eligibles, your Medicare, Medicaid beneficiaries, but they're an incredibly small chunk of that population. It is primarily affecting children that were eligible because their parents lost a job during COVID, but now they're reemployed, or it's affecting people who maybe went into a nursing home for rehabilitative care and are qualified for a long-term care waiver. They've been out for a year and a half, but Medicaid literally was not allowed to disenroll them. Here's the big thing that I think agents should be aware of. And if you want a project to lobby your states with, start lobbying for special enrollment periods for folks to pick up a med sup if they are losing Medicaid. Not every state allows that. Not every state allows that. And you've got a lot of people that, because they were on Medicaid, it was literally against the law for an agent to sell them a med sup, even if they were not actually eligible anymore, but just happened during those 3 years. There's a lot of people that are going to miss out on their one chance to get a Medicare supplement because of this weird glitch in Medicaid not being able to disenroll people. Yeah, something like that.
The other thing that I've been seeing too is having conversations with carriers. They are struggling because they're getting notification from the government who is no longer eligible. And it comes back to the chicken or egg situation where they're getting notified saying these people are not eligible for full Medicaid anymore, so they do not qualify for these full dual plans that they are enrolled in. So then the carrier, maybe it's things like the government being behind, maybe it's wrong addresses, they haven't updated it with the Social Security. Regardless of the situation, if the client was not notified, the carrier is notified. So the carrier then legally has to drop them from that coverage. That person is now disenrolled, doesn't have that dual plan anymore. And if they didn't realize they were disenrolled, maybe they missed a piece of mail, whatever, they go to the doctor, get a claim, they're now liable for that claim. It's just been a chicken or egg situation. The carriers are going, do we notify them before they get notified? We're not always getting notified. Each state has their own process. So on top of that, they might get this mass amount of people who don't qualify anymore, but the state's taking their sweet time, or maybe they actually acted really quickly. It's just a huge mess where the carriers are then looking at like, how do we handle this too? Because that turns into a complaint to Medicare, which hurts their star ratings and it's just a huge trickle down effect of all of that. So it's been super fun. Chicken
or egg, either way, everyone's getting fried. That's just not going well.
Dad jokes are continuing on. That actually kind of leads into the proposed rule.
Yeah, I tell you what. So this is actually really good speculation, because with the proposed rule it's actually a 2025 rule, so it came out so early this year.
It did.
Normally it doesn't come, the proposal for following plan year usually doesn't come out until early December, and then gets finalized in April or May. This year it came out in November. The 2025 proposed rule That's policy and technical changes to the Medicare Advantage program and, PACE and cost plans and all those other things that most people don't care about anymore. But you got all these changes, and don't get me wrong, this is 486 pages of proposed regulation, but the thing I want to focus on right now is changes to dual eligible plans. So CMS is taking a very interesting approach and stance to really key in on managed care organizations, really key in on promoting enrollment for dual eligible individuals in MCOs, so Medicare and Medicaid plans that are maybe managed by the state or done in cooperation, better integrated with the state Medicaid program, not just your normal traditional DSNP plan. And they're looking at extending the, instead of the quarterly DSNP SEP, looking at moving that back to a monthly SEP, but only to enroll in one of those integrated care plans. Not if it's a regular DSNP plan, it would theoretically still be a quarterly. And again, reminder, proposed regulation won't be finalized until Easter, probably.
It's all speculation.
Yes, absolutely. But lots and lots of stuff going on with that. Looking at changing how they classify Medicaid lookalike, DSNP lookalike plans. So right now, DSNP lookalike plans are prohibited, so they're canceling contracts with plans that are DSNP lookalikes, meaning they're a non-SNP plan, but more than 80% of the enrollees in that plan are dual eligible. So those plans are currently up for termination under current rules. Or right now, what they're looking at in this 2025 rule is over the next few years, lowering that threshold, dropping it down to 70% of members being dual eligible, and then tapering it down even further to 60% and potentially further than that, where if you've got a non-SNP plan and, more than half of the members are dual eligible, your plan's up for potential termination because it's a DSNP. They're going to consider it a DSNP lookalike.
Yeah, and a big goal of that was just freeing up Medicaid dollars. Obviously, we have a lot tied up, hence the Medicaid redetermination. So it all kind of circles back to that.
It really does. And there's so many things going on with Medicaid. You got 2 buckets of money. There was a period of time in I think it was about 2018, 19, somewhere in there right before the pandemic, where the number of people on Medicaid actually eclipsed the number of people on Medicare. And then, of course, through the pandemic, it grew exponentially. We're at a lot more people on Medicaid than Medicare, but a lot shakier footing for funding for that program. So one of the big things I think is happening is they're just trying to free up those dollars for Medicaid, because there are a lot of things that Medicaid does at the state-by-state level that Medicare can't do. If you look at some of the reports on like changing demographics in Medicare, not in Medicare, but in the country, there's a lot of reports about how, by, I think it's like by 2040 or 2050, like 1 in 4 Americans will be, Latino or
immigrants.
More than that for just, if you look at any immigration status. But, with that, there's a lot of folks that may be undocumented that won't ever be eligible for Medicare because they don't have the work history or they're not lawful residents. But depending on what state you're in, they may be eligible for Medicaid benefits. So if you're in a state where you've got a lot of dual eligibles that are not receiving integrated care, putting them into that integrated care plan can free up some of those Medicaid dollars for some of these other classes of individuals that may qualify for Medicaid benefits, but they're just not the funding.
Yeah.
So as we look at, at some of those other groups of people aging and not being eligible for Medicare, what's the alternative here? And I think Medicaid is the alternative in some cases.
So going into money, I think that kind of leads us nicely into our next topic, which is hospitals and quality measures and closures. There's a lot going on with access to care, and even access to like skilled nursing facilities. So we can kind of dive into like what all of that means. But in the future, we're definitely seeing a lot of kind of finagling things that we're seeing with quality reporting and things.
Just cost reporting. Looking at the transparency laws that came out and trying to get all these machine readable files, which are totally useless, by the way. I don't know if you ever looked at them, but like they're not useless. But listen, the whole point of machine readable is a human being cannot make sense of it. You can't look at one of these machine readable files and glean any reasonable amount of information that's useful to you. But there's some really cool tools out there that take that information and turn it into a human readable format that you can get value from in looking at comparing costs of various hospitals and things like that. doesn't necessarily affect Medicare directly, but some of the fines and penalties for not complying with transparency laws do and can affect Medicare benefits.
One of the things when Sheila and I were kind of prepping for this podcast was that not every hospital applies to quality measures. So and there's a lot of different reasons why, but like, you know, if they are, let's see if I can grab it, if they're teaching hospitals, large hospitals, there's just different unfair penalizations because you're looking at different hospitals and that they're on different scales. So sometimes they'll say like this many hospitals have to report this way, but then you look at all the rural hospitals and they don't apply.
Yeah, or, you know, so if you look at some of the quality measures regarding readmissions or regarding, you know, some of the other quality ratings, like you'll see a news article come out every year. It'll be like half of hospitals failed this quality metric that they have to report to CMS and are subject to penalties. And then you'll read the article and it's like, well, actually, out of the, you know, 1,213 hospitals, CMS is only finding 6 of them because some of them are critical access hospitals. Some of them are rural emergency hospitals. Some of them are, you know, have some other designation that even though they're not meeting these minimum standards, they're still not subject to some of these penalties. And it's, you know, it can be really frustrating to not maybe understand why those penalties just don't apply to some hospitals. And I think
which goes into how they are getting paid by the government too. Absolutely. So it's interesting to see, like, you know, the government is trying to find some sort of unified system to like give money to hospitals, and it's not fair and it's not unified.
Well, and I think that brings, like, and don't get me wrong, this is a debate that can go on for days, but like the question is, if you've got a hospital that is, say, a critical access hospital, and it's, you know, the only hospital in the county, the only level 1 trauma center, whatever the case may be, critical access hospital, and they're not performing well, it is really hard to say the solution is to take money away from them.
Or to close it in general. If that's the only access to care that a rural person has is to go to a critical access hospital or an emergency room type situation, like, how do you justify closing that?
Exactly. And I think that's one of the big things that, like, it's so difficult because obviously you want to incentivize better performance, incentivize meeting these benchmarks, but penalizing for not meeting these benchmarks can result in
more people
decreasing access to care. And so it's quite the balancing act that I am very glad.
I feel like we're seeing a theme here. Like,
yeah, absolutely.
They could go this way or this way.
That nobody wins.
Yes. We actually did do a episode called Rural Hospitals, episode 3. So you can definitely dive more into that if you are curious on rural hospital closures, on rural hospitals turning more into like emergency room, critical access hospitals, just to keep them open, and what that does to that local, all the local people.
Sure. Yeah. I mean, it's crazy. And I think that's something that we'll continue to see as a trend is, you know, as we see more hospitals struggling financially because of payer mix, because of location, because of population density, you know, we're seeing a lot of them just kind of be stripped down to, you know, an ER. It's just a place to stabilize and transport to a better center of care. And that is really hurting local economies. It's hurting local job markets. It's hurting people's access to care, because at a time where, well, like we talk about your dad all the time, who's now retired, but you know, there was a time in his career where he said, man, just like going it alone just is no longer feasible. I need to affiliate with the hospital. And if your local hospital has been stripped down to nothing but an ER, well, a provider can't even really affiliate then.
Correct.
So they don't. Now you have a community that not only doesn't have a hospital, but they don't have any specialists. They don't have any primary care doctors even, unless you've got one old private practice doc hanging on for dear life. So you've got folks who cannot get routine care without traveling a long distance. My parents both live in North Missouri, almost 2 hours away from here. They're both in Columbia today for doctor's appointments. That's what they have to do. They have to drive 2 hours to get, reasonably decent care. And these aren't emergencies. This is just where their doctors are. And because we don't have those specialists up north where I grew up anymore. And, doctors aren't being replaced as quickly up there. They're, as compared to Columbia or other centers of care. And Columbia is a really odd example because we have just like this insane healthcare ecosystem in Columbia with 2 major hospitals, a ton of private practices. We're a bad example, but it's still really indicative of what a lot of people experience. And unfortunately for a lot of people, especially lower income individuals, it's not even a choice of, well, I've got to travel a long ways for care. It's just, well, wait until it's an emergency. Go to the emergency room.
Yeah.
They'll air vac me out there.
Yeah, it'll definitely be something to keep an eye on, of like access to care for people living in rural communities. And speaking of access to care, skilled nursing facilities was something else we wanted to jump into. We were looking at, obviously baby boomers are turning 65 and we've got a lot more people aging. How do you age gracefully with support, with care, with skilled people to help take care of you? That's going to be a struggle in the coming years. According to the National Library of Medicine, we looked up, basically it looks like there are only 130 beds per 10,000 adults age 65 or older. And that's since the 2019 study. There are a lot of people, 1 in 3 people have a chronic condition over 65. Mm-hmm. A lot of people are going to need skilled nursing facility care. So what does that look like? Like, there's not enough beds right now.
Not enough beds and not enough people. So, one of those, and again, it's unintended consequences. We look at the current state of nursing homes and we go, man, some people are not getting the care they need in nursing homes right now today. What do? Well, we change the staffing rules. Mm-hmm. Law passed earlier this year to change requirements for staffing nursing homes, increase the number of registered nursing hours per patient, increase the number of care hours per patient for non-RN staff. And that's great for quality of care for the people that can get into a facility.
Mm-hmm. Yes, that is also.
But it does one of two things. It drastically increases costs, because here's the deal. We have these better staffing requirements, but not significantly better pay, not better reimbursements enough to, to account for that. So you either have facilities that have to hire a lot more people for accept a lot less patients. Neither is a good recipe for quality care, not to the level that it's needed. So we talked a little bit about home care while we were putting this together. And I said, honestly, it's going to end up like substitute teaching.
I thought that was a great analogy.
I remember when I was a kid, like in school, to be a substitute teacher, you had to have an associate's degree. You had to, pass some test or something, and you could go be a substitute teacher. Now, as long as you're not a felon, you can be a substitute teacher. And it's just, that's a little bit of a stretch, but not too far off.
Well, we even talked about okay, so there are not enough skilled people, but someone has to take care of these people. So what if, and we're starting to see it now, where companies are actually training loved ones and to care for that person. So training them to do this, and then submitting claims and basically taking kind of the claim, but paying that loved one, because there are literally not enough skilled people to take care of the number of people who need the care.
Well, and you can see that that's a trend that the government expects to continue. CMS added codes to their coding modules to specifically compensate providers for training caretakers. So right now, the solution from CMS is we're going to pay doctors to train your spouse, your child, your uncle, your niece, whoever it is. We're going to pay a doctor to train this person how to give you your insulin shots, how to change your catheter, how to whatever it is. Right now, uncompensated care is the solution, and it's a bad solution. Mm-hmm. But, and we've already seen this. You've got that sandwich generation. They've still got kids at home. They've got parents they have to care for. Gen X is getting hit with it right now in a big way, and even older millennials now. But this is such a problem going forward as we continue to see baby boomers age, and then even after the baby boomer generation kind of wraps up here in the next few years, we're going to continue to see this be an issue as the costs of care continue to skyrocket. The availability of insurance-based solutions continues to be more and more difficult. Look at long-term care plans any day, even look at short-term care plans. I haven't seen any super up-to-date data, but the last time I looked, it was like people on average need long-term care for 2.5 years. The statistic that should terrify most people is in most cases, people should have had long-term care for on average 2 years before they actually got into it. Mm-hmm. And that means that a spouse or a child was performing uncompensated care or paying for a home health aide or something like that, that is really dragging down that next generation. And I think that's a big concern that people should have, because if I'm spending all of my money taking care of my parents as they age, what happens when I'm older?
Yeah, and your children are not benefiting from all the money that you just spent on your parents then too.
Absolutely. They, for years they've been saying that, like, as the baby boomers age and then, pass away, it's going to be the largest generational transfer of wealth in human history. Trillions and trillions of dollars in generational wealth transfer. Unfortunately, a lot of people thought it was going to transfer to them instead of nursing homes and taxes and a lot of other places. But that's where all this money's going to end up. And assets. You're going to have to sell your house. You're going to have to, all of these things. If you're in a state that, you're saying, hey, we'll just depend on Medicaid, that's great. A lot of states will go after the estate of your loved one to help compensate for what they spent taking care of them in a long-term care facility. 21 states have filial responsibilities filial responsibility laws where you, as the child,
Are responsible
for caring for your parent or loved one, and can be charged civilly or criminally for a failure to do so. Now, that varies a little bit state to state, but there are several states that legally require you to provide for the care of your parents.
And this may be a bigger issue as we see less hospitals, less beds, less home health care facilities, less home health aides. I actually ran into it with my own grandpa. He wanted to go home basically to gracefully die, but there was literally not a single home health aide or nursing home person who could take care of him, a skilled person who could take care of him in a home at his house, because he lived in a rural area. That was completely opposite experience we had with my grandma, who had waited 2 years to find an unassisted living facility that then can transition into a skilled facility and then hospice. She used the hospice towards the end and was able to go home, which was her home for 2 years that she about 2 years that she lived in there. But she was one of the lucky ones. But she did live with my parents for 2 years prior to waiting to get into one of those facilities. So it is interesting, the burnout that we'll see in terms of, the sandwich generation, like you said. And then in addition to that, the burnout with jobs. We just finished a pandemic where people got overworked and they're exhausted. And now you're still asking them to still take care of baby boomers, our largest generation that's aging. So it'll be interesting to see. I think we're going to be paying attention to a lot more situations in the news where we're going to see a lot more home health. We're going to see a lot more shakeup of how do you handle the aging population.
If you have kids under the age of 6, you're going to understand what I'm about to say, that it is quickly getting just as hard to get your parents into long-term care as it is to get your kids into daycare.
Very true.
It is the exact same problem on both ends
on
of
the
the
other
life
end.
spectrum.
Yeah, a lot of people lost their jobs on the childcare side too. Fun fact, I told the childcare facility that I was pregnant before my own parents because I needed to secure a spot. So he is completely right on that aspect.
Absolutely. So last thing, because I know we're running super long, but this is a really fun episode, but let's talk about star ratings, because I think the changes to star ratings, the changes to plan quality ratings on the Medicare Advantage side is definitely up for a lot of speculation. And
let's go back for a second too on star ratings. No, we can still talk star ratings. I just want to go into like the purpose of a star rating too, is basically for government reimbursement to plans that are doing what they say they're going to be doing, and to help guide agents and clients into plans that are performing well and have the metrics are member experience, customer service, plan performance, chronic conditions, and staying healthy. So basically better servicing this client, which in turn hopefully makes them stay healthy.
There's problems, though.
There are problems.
So among those problems is that these are all rated based on a benchmark set of statistics rather than a comparative analysis. Something that, in my opinion, would make more sense would be a comparative analysis where you have, tiers of plans based on performance of these metrics, where you can basically carve out the top 10%, the middle 25, the lower 25, and the bottom 10%, something like that. You'll have 2 or 3 tiers for that 1 through 5 star rating. But currently it's just all comparisons to the benchmarks, which is why you see a lot of 5-star plans, a lot of 4-star plans, a lot of 3.5-star plans, but less and less the past couple years, unfortunately.
Well, and you've been seeing things like member experience with health plans. Like, COVID, a lot of them weren't using it. They were staying home. They may not have gone to their primary care. They were staying away from the hospital because they didn't want to get sick. We're starting to see a complete change of that, where people are now going to the hospital, getting diagnosed with things that maybe were sitting dormant, or they didn't realize they had a chronic condition, claims happening. So they're using their plan, which means that they may not have the best experience. Maybe they
have more chances to be disappointed.
Yep. Maybe because they waited so long for their chronic condition to get diagnosed. Now more people are getting diagnosed with chronic conditions for the plans.
Well, and I also think it's important to recognize that during the pandemic, CMS basically gave plans a pass. They did not measure certain quality metrics. And that's why in 2021, we saw a huge spike in the number of 5-star plans available that has kind of tapered off since then. But yeah, absolutely. You've got people actually trying to use their plans, in a big way for the first time in the past couple of years, and it is drastically impacting that quality because over the course of the pandemic, we saw carriers saying, man, we've got all this money to play with. We need to come up with some unique and fascinating benefits, because at the same time, we also had programs like value-based insurance design, special supplemental benefits for the chronically ill. We had some of these other innovation programs coming into play that allowed them to get more creative with benefits. So they started just trying out a bunch of new stuff. And some of it was really hard to use.
Yeah. We ran into like Uber, like people were like, oh yeah, you can use ride transportation, but then how do you like actually use it? Networks, like, they would say like, here's unlimited dental, but there's nobody in network. Or benefits cards. We even had an issue with like the cards like physically just not working. Like they'd be standing at the register with healthy foods trying to check out and the cards just weren't working. So like, I think the idea.
I remember like they're early on when the first plan started offering utility assistance, like you call up your light company and they'd be like, we have no clue what you're talking about. We don't know how to process a payment from this, especially a partial payment. But for some reason, the Walmart customer service counter could help them with it. And it was just like the weirdest stuff.
Yeah.
But that all impacts quality ratings.
Correct. Yeah, so I think what we're going at is our prediction is it'll be harder for carriers to get the 5-star rating. So we will see less and less carriers with that 5-star, with that SEP to enroll all year long. And it may be, who knows, maybe they will relook at it down the road of like, how are they measuring it? What is it measure? But that is literally how the government reimburses a lot of, gives money to carriers to create their benefits and their plan. So
yep.
Maybe that'll be something up for grabs in the future with the government. And speaking of the government, we have really, really short stuff because I know we're running along. Just some of the changes that we think we'll see in the future with government as well.
Drug coverage, PBMs, those are all going to be huge buzzwords in the next election cycle, I strongly suspect. But there's a lot of things on the table. There are things that we've been fighting for a long time, like COBRA's creditable coverage. So allowing that special enrollment period for folks that are maybe continuing that work coverage because of a lagging spouse or some other circumstances, trying to ride out to the end of the year so they don't waste a deductible. That has long been a fight. But you're also seeing some speculation and some scrutiny of things like so many special enrollment periods. There are these FEMA SEPs.
Every federal emergency.
Oh my gosh.
There's so many of them.
Yeah.
Which I think was causing some of the complaints to Medicare too, because call centers were taking advantage of them, and so many SEPs.
No, it definitely was. I mean, and then I think, in the other side of the coin, just in terms of that, again, check our last episode, value of an agent and FMO. If you look at the value proposition that agents have for a client, there's a lot of questions about, so the scope of appointment came back, 48-hour rule, we've got that. What's the purpose of that document? Does it still make sense? Does it need to be changed? Does there need to be some additional, safeguards put in place for Medicare beneficiaries? And then even looking at, how that's bleeding into other industries or other parts of the industry, where now with the ACA marketplace plans, we have something that is basically a scope of appointment that's required for enrollment there. So looking at kind of this, crossing over effect of keep an eye on Medicare, because it's starting to affect a lot of other things. I've said for a long time, and I've said this in a couple speeches, and it always gets a great laugh. I say Medicare serves two primary purposes for the federal government. Neither of them is taking care of Medicare beneficiaries. the first big purpose is it's the test kitchen. They get to try things out, play around, create new ideas on how to deliver care, how to pay for care, things like that. The second big purpose is that Medicare is the big stick that the federal government gets to swing at pharmaceutical manufacturers, at insurance carriers, at providers, because it is one of the largest pots of money. $1 trillion this year is what we're anticipating that providers can expect to see. So it is just such a huge stick to swing, and that's why I think it'll feature ever more prominently in political discourse next year, in changes to policy, and in how it might impact not only your business, but your clients' actual experience in getting care.
I think that wraps it up very perfectly. We did a lot of fun speculation today. We did Christmas past, Christmas present, or I guess AEP. And we had a very good Medicarol. We're doing dad jokes. That was his joke. And I think it's important to kind of not only know kind of where your Medicare came from, what rules or regulations are happening right now, but also how that just changes into different alternative universes and how things pan out going forward. So we did a little speculation today. We had a little fun. But I appreciate you watching. Have a very meowy Christmas. Thank you for taking care of your clients. Happy holidays, and we'll catch you on the next podcast.